Okay, let's start. It's 35 at my watch. So
Great.
good morning, good evening, good afternoon, everyone, from wherever you're joining. My name is Wafa Joel, and I'm a senior lecturer at the School of Computing and Information System in the University of Melbourne. And I'm very happy to chair this session today. Today we have one of my colleagues who's giving a talk, Dr. Simon D'Alfonso, who's a senior lecturer at the School of Computing and Information System at the University of Melbourne. Simon's work focuses on the application of digital technologies, ubiquitous computing, and artificial intelligence to mental health and psychology, and like in general. He's also interested in exploring the philosophical and ethical dimensions of AI and digital technologies. So Simon, the floor is yours.
Thanks, Wafa. So the title of today's talk is Mental Health Digital Phenotyping Research, and within CIS, which is, as Wafa has said, the School of Computing and Information Systems. Some of you might know what digital phenotyping is, but for those who don't, here's a bit of a definition. So our increasing usage of smartphones, wearables, and the internet, particularly social media networking, has increased what can be termed our digital footprint or data exhaust. And digital phenotyping is about mining and analyzing an individual's, or groups for that matter, digital footprint to gain insights into their mental health. And these insights are insights of clinical value that could be used to anticipate mental ill health and inform treatment. So more broadly, we can have this digital phenotyping stuff in relation to human behavior generally, but we can also use it for clinical mental health applications potentially. Here is just a formal definition of digital phenotyping taken from one of the first papers on the topic: the moment-by-moment quantification of the individual level human phenotype in situ using data from smartphones and other personal digital devices. And another term that has been proffered for this field is also personal sensing. You might see that around. It's perhaps a little more straightforward in some ways. Just to explain what digital phenotyping means in terms of its origin. So we know that phenotype is a scientific term used to denote an organism's, including humans, naturally observable physical and behavioral characteristics. Thus, digital phenotyping is simply the process of measuring or identifying certain behavioral characteristics based on an individual's digital footprint. Now that we have that terminological introduction out of the way, just wanted to quickly show this illustration that I've taken from this lovely paper from a few years ago. And it's just a quick way to convey this idea of digital phenotyping. You start off, say, with your sensors in the bottom layer. Most of these are smartphone sensors, but you can have other sensors from other devices. This is the raw data. This raw data is then converted into low-level features or informational features. From raw geolocation coordinates, we can get things like location type, or the extent of movement, or the entropy of movement, and so forth. We then go from the low-level features to the high-level behavioral markers. So what would be an example here? Missing phone calls or not engaging in much communication via the phone could be an indicator of social avoidance as a behavior. And then finally, if this all works from first layer to third layer, we might be able to make some types of diagnostic determinations based on this process. High level, depression, anxiety, various other conditions, other clinical constructs. So in summary, this is the smartphone digital phenotyping gist. The usage and sensor data from a smartphone can be collected and analyzed to infer information about its user. But I do want to point out that I consider there to be two types of information, broadly speaking. The first is contextual/situational information. I can determine, say, if somebody's in a park, or I can determine perhaps if they're in a socially crowded environment. And the second is behavioral. Are they sedentary? Are they socially active, etc.? And this is the spiel I generally use to sort of sell this possibility of digital phenotyping in a clinical mental health space. First point is that traditional mental health care is resource limited. Second, clinical sessions and patient self-reporting can be affected by certain subjectivities and assessments and accounts of behaviour. Third, existing clinical practices are inefficient in detecting early stages of mental illness. Standard methods are based on face-to-face interactions and assessments with clinicians conducted at set times and locations. Fourth, once a clinical therapy session is over, there is no sufficient way to monitor a patient's behavioural patterns in their real day-to-day life. And finally, continuous smartphone-centered information, unobtrusively collected, can fill this gap, providing value to both patients and clinical care providers. I'll just now quickly go over some examples of these sensors, how they're used, and some studies, some early studies which suggest some results. The movement and physical activity sensors like GPS, accelerometer, this one's a bit more obscure, a gyroscope. Wafa, you've got your hand up? Is that...
Yes, apparently some people cannot see the slides. I don't know if you have to go into view and do full screen so that I see the slides moving, but...
Let me try full screen.
Yeah, I also see the slides.
Is that better for those who can't?
Clear?
Claire? Claire could, no, somebody, I think most people can see the slides.
It might be Claire's
except for Claire.
connection. Okay. Shall I continue in that case?
Yes, maybe you try to
I
join
think
again.
so.
Yeah.
I'll just start sharing again, actually. That might do something. Okay. So these sensors can be used to distinguish sedentary and non-sedentary states and to investigate connections between movement and conditions such as depression, such as some of these early results. This one suggests that people who are depressed tend to have less spread in the locations they visit. And this is one of the first themes that was established in exploratory digital phenotyping research. The paper is titled Predicting Depressive Symptoms Using Smartphone Data. I just wanted to quickly mention this possibility too. I like this idea. One small study found some modest, though inconsistent relationships between the time spent in certain locations and mental health. Depression and anxiety scores were lower for some people who spent more time in spiritual locations, and non-depressed people spent significantly more time at work. So beyond just sort of getting quantitative geolocation features, trying to also identify semantic places where people are visiting and how that might connect to their mental health. So what was the title of this paper? Mobile phone detection of semantic location and its relationship to depression and anxiety. There's the communication and social engagement sensors. We know these sensors, social media app usage, SMS message counts, calls. We get incoming, outgoing, answered, unanswered, all that stuff. One study here found that certain reductions in the number and duration of outgoing calls, as well as number of text messages, were associated with relapses of schizophrenia. And Bluetooth is an interesting one too. The possibility of detecting surrounding Bluetooth-enabled devices could be used to determine whether the smartphone user is in a crowded or uncrowded space or surrounded by a lot of people or not. And he was one of the first proof of concept studies of this idea of using Bluetooth to determine social proximities and activity. And finally, the screen and interaction sensors, the keyboard and screen interaction sensors, that an individual's tactile interactions with the screen, such as typing, pressing, swiping. One study showed that both average delays between keystrokes and auto-correction rates, that is misspellings, correlated positively with a common depression scale. And in another study comparing two groups, one with depressive tendencies and one without, the depressive group showed longer periods between pressing and releasing a key. And this indicates a slower motor reaction time or psychomotor retardation, which is a feature of depression. And this could also be used for neuromuscular, neurodegenerative conditions possibly. If somebody has a normally certain type of healthy typing rate, but then over time that's slowly slowing down, then that could be a signal of something. Okay, moving on to the actual research that's occurring in CIS on these topics. First, just want to introduce the Aware Smartphone Sensing app, which is our home-brewed smartphone sensing tool that we use in some of our studies. So the Aware is an app framework that allows data to be collected from a range of smartphone sensors. And it also includes functionality to deliver EMA or ESM questionnaires. They're more or less interchangeable terms. EMA stands for Ecological Momentary Assessment, and ESM stands for Experience Sampling Method. Essentially, it's just about sending questionnaires in situ at opportune times throughout the day to get responses on various questions from study participants. And we've developed our own version. This is our version of the app called Aware Light. For those who are interested, it's open source, free to use. So you might like to check it out. I'll just paste the links as I go into the chat window, and there's just a screenshot of it. What's this one showing? This was a test study with a few sensors turned on. You can actually get the light, the ambient light of the phone, networks it's connected to, and screen usage in this case. You know, if somebody unlocks their screen or when the screen closes and things like that. Okay, so quickly, a couple of digital phenotyping studies we're actually running or have run. The two are SmartSense D and StudentSense. Some of the colleagues on these studies, working with me on these studies in this Zoom. And here is another link to the CIS page that covers these two studies. I'll put that in the chat window too for your perusal later on. With SmartSense D, it's a digital phenotyping study involving a cohort of 41 adolescents diagnosed with depression. And these were recruited from Origin, which is a nearby youth mental health institute, and they run a few Headspace centres in Melbourne. Headspace is a youth mental health government-supported service initiative. So myself and one of my colleagues, Liana Schmal, initiated this study a few years ago. We collected smartphone data with Aware Light and actigraphy data, that's the wristwatch device, over an 8-week period. Some of the smartphone sensors, we had geolocation, the screen, communications, keyboard interactions. I think we also actually obtained consent for not only like the screen touch episodes, but the characters that we input into the keyboard, so we can do some natural language analysis of that semantic textual content. There were EMA questions twice daily, midday and evening, concerning positive and negative effect questions. How happy did you feel? How relaxed did you feel? How stressed did you feel? And a few other things. And we also took some psychometric assessments, self-report measures that were taken pre and post the 8-week period. Some of these measures are DASS is a depression, anxiety, and stress scale. QIDS is a more specific depression scale. UCLA measures loneliness. PSWQ measures worry. RRS measures rumination. And this one, NMPQ, is a bit different. It's an interesting one that measures the first scale that purportedly measures the notion of nomophobia. I'm not sure if anyone has ever heard of nomophobia, but it stands for no mobile phone phobia. And it's a purported phenomenon whereby people have this, phobia, in double quotes, if you will, of being without their smartphone. And I'll talk a bit more about that in a couple of slides. And finally, we also administered at the end, after the 8 weeks, a debriefing questionnaire to capture participant attitudes towards such smartphone sensing and their perspectives on its feasibility and acceptability. Some of the outcomes, and we currently have an outcomes paper on this being generated by one of our PhD students, Andreas Camargo, and he's found some interesting things. This pilot study was safe, feasible, and acceptable. That's good. That's all I can really say about that. I'm more interested in what comes after that. We found a positive correlation between average positive daily mood, as measured by the EMAs, and these three things: the number of outgoing calls mean duration, and distinct contacts received through messages. So it's indicating that the more social interactions you have, and largely our social interactions are mediated by phones these days, maybe there's more of a tendency to have in general, more positive daily affect. A positive correlation between positive mood and normalized location entropy. We also found that negative mood was positively correlated with maximum duration of phone unlocks and average interkey delay during phone interaction. So this is like the flip side of the coin in a way. It's kind of saying the more duration on your phone, just maybe looking through things, more negative mood tendencies. These are all very preliminary things, exploratory findings that would, be in need of some future more detailed confirmatory studies. And we also, Andreas primarily, also did a linear mixed model, which showed significant negative association between daily EMA positive mood ratings and QIDS total score, which perhaps isn't too much of a surprise. If in general, day to day, you have a positive affect, then you're going to probably have a lower overall depression score at the end of that 8-week period. And I'll just move on to the next part, which is the nomophobia research or exploration of this study. As I said, we did take the NMPQ measure, and Tianyi Zhang, who's one of my PhD students also, she's been working on the paper for this. It's like a spin-off paper of the SmartSense-D study, and found that nomophobia was found to be associated with depression, in that the DAS, the D part of the DAS, depression factor, and the QIDS factors of mood and energy fatigue had a positive correlation with nomophobia. So, to simplify that, the more nomophobia one has, maybe the more likely they have depression, a higher score for depression. Daily positive affects had a negative correlation, particularly happiness and relaxation. And that the more happiness and relaxed someone was, the lower their nomophobia, and a higher comfort with smartphone sensing had a positive correlation with nomophobia. And our interpretation of this, mainly my interpretation, was we could perhaps posit some nomophobia privacy trade-off, in that the more one feels, compelled to need to use their phone, perhaps the more willing they are to sacrifice their privacy, or the greater comfort they have with just being sensed in various ways on their phone. A little speculative at the moment, but these are some, initial tentative statistical quantitative results. For all of these to pass the test, the only results we accepted, because we did an exploration, so we had non-significant findings, but for these significant findings, the test they had to pass was, we used Spearman rank correlation. They needed to have a value, an R value, more or less of 0.3 or above. That's in line with Cohen's criteria for significance, and 0.3 or above would be treated as moderately good as a correlation in the behavioral sciences, and a p-value of 0.05 or less. We also found that less geolocation movements were accompanied by higher nomophobia in general, and this is actually a tabulation of some of those results. You'll see that all these Spearman rank correlation coefficients were above 0.3, and with adequate p-values. I'll pick one of these, like say the time spent at home. The more one spent time spent at home, higher nomophobia, and a few others, but I won't go into those. I'll just leave that there for a second while I get a glass of water. And just quickly, the StudentSense study, which is currently happening. So we collected the data for SmartSense-D a couple of years ago, and now we're now working through that data and analyzing it. StudentSense is a digital phenotyping study involving a cohort of around 150 University of Melbourne students, and it's actually been run now over semester 2 of 2023. There are some of the sensors that we're collecting. Some of them we collected in the previous study, but we also added battery to this one, Bluetooth, and this new hardcore sensor we've just developed, screen text for actually every few seconds, just scraping the text from participant screens, phone screens, storing it in the database in encrypted form. Let me add, this is very sensitive information, the whole textual content from somebody's screen, but it's a very rich, data set now where we can hopefully do some natural language processing analyses over this screen text content and try to find some interesting things with it. We're also administering some EMA questions, but we're doing this one less frequently on a weekly basis, and we're administering some items from the positive and negative effect schedule. It's the main of the PANAS. It's one of the main scales to measure positive and negative affects. And this is the World Health Organization, the WHO-5, which is just a general well-being questionnaire. It's a really simple one to administer with 5 items. And our psychometric assessments are these ones taken pre, mid, and post-semester. The Big 5 Inventory, which is a personality scale, to measure the Big 5 personality traits. That's a shortened version of the UCLA loneliness scale. That's the DASS, depression, anxiety, stress. We've added these 3, the smartphone addiction scale, this mental health continuum short form, which is more of a general well-being and positive psychology scale, and this novel scale here, the college student subjective well-being questionnaire, which has just been developed in the last couple of years, and we thought we might explore that in relation to some of the data we're collecting also. Okay, so in the final part of this talk, I'm just going to talk about personal sensing analytics and the SenPsi project. So what I've just gone over is an example of the digital phenotyping research agenda, which has largely consisted of quantitative studies exploring statistical associations between smartphone data and psychometric outcomes. The SenPsi project, on the other hand, is researching and developing a web dashboard platform that is about collecting an individual's digital footprint data and presenting it in a meaningful way for use by mental health clinicians so that they can use such information manually to augment their practice and inform their own judgments in treating clients. So basically just think about getting this data, converting it into meaningful information, visualizations on a dashboard system that a clinician can look at, say just before they're about to have a psychotherapy session with their client. So that could maybe facilitate their practice and inform them as to what their client has been doing, during their last psychotherapy session and such. And here is the link for that page on the CIS website if you're interested. And this is one of the papers, or this is like an initial paper for this project where we're trying to get clinician perspectives on how digital phenotyping can inform client treatment. And my colleague, Simone Schmidt, has been helping out with this. She's a qualitative researcher, so she did some of the qualitative research for this, namely a reflexive thematic analysis study of interviews involving mainly clinical psychologists, generating ideas and a framework for understanding how digital phenotyping can inform, augment, and innovate client treatment. And Simone and I started off with this question: how can digital phenotyping inform client treatment? But we also discovered that there were 2 other sub-questions or extended questions that were elicited from this process and these interviews with the 20 mental health practitioners. The second one was, how should digital phenotyping inform client treatment? And thirdly, why should digital phenotyping inform client treatment? And Simone came up with this thematic map. We have 3 super themes of ethics, praxis, and value, and the 5 main themes of 1, the client controls their data and understands how it will be used. 2, the clinician is a steward of the client's data. 3, technology signals mental states and is unhealthily or healthily employed. Sensors and EMAs informing treatment. And the value in digital in this type of manual digital phenotyping, being able to supplement limitations in therapy by generating awareness and engagement. For those who are interested, I'll go to here, I'll paste the link to the paper that was published on this qualitative study. Here, there, and a final couple of slides. Some discussion and highlight points. Responses among mental health clinicians to the potential of using digital phenotyping in their practice were largely favorable. So this is from this SenPsi qualitative study I was just talking about. These are the themes that I've just mentioned. In digital phenotyping systems, clients should control their data and clinicians should steward it according to the client's needs. Digital phenotyping can capture useful information pertaining to a client's behavioral life that is often not conveyed in a therapy session. So this is the big one for me. Clients, people in general, they lead rich behavioral lives in between their mental health service sessions. So if we can use any of that in a discreet, judicious way to help facilitate and inform mental health practitioners, might be worth trying. And finally, a minority of clinicians felt that digital phenotyping would not be that useful, as a client's recall and reporting capacities would suffice. Fair enough, I kind of pushed back against that in the discussion part of that paper I just sent a link to. Final note on some SenPsi developments. We're working with research clinicians at this stage to develop and test this platform. We have a very rough prototype of the dashboard web platform at the moment, but that needs further work that we're hoping to continue. And a final point I like to make is that with the advent of digital/data approaches to mental health, what could be termed mental health analytics or the more general psychoinformatics, there will need to be open-mindedness among practitioners and paradigm shifts in mental health care. And upcoming generations of mental health clinicians will require a new data savvy. So I think needs to be this movement to educate clinicians so they go from the pen and the paper pad, and the fainting couch, which they can still keep, but start to incorporate clinical decision support technologies and AI technologies perhaps into future practice. And that's it. Here are just some links. Thanks for listening.
Great, thank you. So thanks, Simon. So I guess it's time now for the Q&A. And if anybody has questions, don't hesitate to unmute yourself and ask. And I can start just to encourage everyone. So I have one question I have related to the last part of your presentation, Simon, was about this dashboard that the clinician might be presented. I'm guessing like when you're seeing this kind of data, you actually can make sense of it just because you can compare with others. So you would see like, where is this patient in terms of its behavior relatively to other people, or do you actually design absolute like thresholds for each of this behavior, saying, okay, this is abnormal, or this is, or do you have like, how do you, how
Sure.
can you make sense of individual data in this?
For this type of stuff, I feel it would be on an individual level. So you establish a baseline for the individual and you see if there are any significant deviations from that down the track. Especially for SenPsi, it'd be a more like that individual personalized level where the clinician has an intimate understanding of their client and a good familiarity with the types of digital footprints that they would typically generate. So it's up to the clinician executing a manual judgment because they know their client and what their digital footprint should look like. I can continue talking unless you have any sub-questions.
No, I understand. I see Bella has her hand raised, so please, Bella.
Hi, thanks, Simon. Really interesting, both from a professional and a personal point of view. And apologies if I missed this because I did join late. But I just wondered, so my work is all around patient and public involvement in research, and I just wondered what was the kind of user/patient involvement in the research, in this research.
So with the two quantitative studies, those SmartSense-D and StudentSense, we go through the usual process of consenting study participants, providing a plain language statement that they have to consent to, all that type of stuff. And with Aware, that smartphone sensing app, they have the option at any time to turn off whichever sensors they want to. So we keep them abreast of the developments, and they have, a vast amount of choice into what they share. For SmartSense in particular, we did, before even starting the study, we conducted a focus group so Origin have a framework to, they have a youth advisory group, and we have the option to make a request to speak some of those youth advisory group members. So we invited them to one of our focus group where we explain the gist of that SmartSense-D study to them just to get their feedback. And I don't remember the exact details, but they did help to shape or to polish in the end how our study was actually executed. And I also, if you're ever interested, I actually wrote about this. You know that blog called Mental Health? I wrote actually exactly on this about if we're going to start using AI in mental health, what would public and patient involvement look like on the topic of AI in mental health? Because, you know, a lot of it has been just co-design of apps and things like that. But AI in mental health is a new frontier. What could PPI mean for that? And I did actually blog about it on mental health. So you can just Google that if you're interested.
Yeah, that's really helpful. Thank you. And I think especially your last point, that's clearly also going to vary across different populations, especially those, you know, who might have experienced racial minoritization or similar, and might have different, you know, kind of perspectives, I guess, on AI and that kind of thing. So really interesting. Thank you very much.
Thank you.
Any other questions in the audience?
I have a question, Simon.
I'm not off the hook yet.
Nope. To what extent do you think the patient should be getting access to this data and sharing it versus the clinician getting access to it? And do you know what patients feel about it specifically?
Sure, that's a good question, actually, because there definitely should be a client-facing portal or thing too. SenPsi is focusing on the clinician side because that's what I'm perhaps most focused on at the moment. I think it would work together with a client-facing side too, some type of, I see the clinician-facing side as being more of a dashboard web portal or something. Perhaps for the client, it could be a more nimble app that could show them some types of information that would be useful. I just think that would be different interfaces. You know, the clinician would have a more perhaps technical dashboard system, and they would use it in some ways. But there definitely would be a client-facing one. I don't exactly know what it might look like at this stage, but it would be something to facilitate or, you know, help the client with emotional self-awareness and various other insights. But maybe somebody else knows what that should look like and they would like to join. Yeah.
Other questions?
All right.
I think related again to the clinician part, how do you think like, do you think they'll need like more training for the clinicians to be able to make sense of actually this type of data? Because they're probably not used to seeing this. So you think that they'll need, yeah.
So sorry, very much yes. I think that's quite an endeavor in itself.
Mm-hmm.
Spreading the word and evangelizing and perhaps trying to at least promote the possibility of exploring this possibility, like in this behavioral health space, mental health space. I see some psychologists in the participant, you know, the Zoom participant list here. So if any of the psychologists who I can see here have any, you know, insights or suggestions, but I think it's very incipient, nascent here at the moment.
And another point is around like training about how to like be you know, be like aware of the fact that this dashboard might be a bit imprecise, and there's like all of this like literacy around how the data is aggregated, and the fact that okay, that's an estimation and not the
Very
Yeah.
much so. So hopefully next year we can try a pilot of this prototype. Say the University of Melbourne clinic, the training clinic down the road from us. I do think and that's the whole point of this manual dashboard possibility, that I think we're a very long way off, if ever, from having these sufficiently perfect, fully automated machine learning systems that just spit out some, be all and end all diagnostic determination, right? You can't just crunch this data and go, yep, depression, yep, generalized anxiety disorder. For starters, mental health taxonomies and diagnostic classification systems are so controversial in themselves, or not straightforward to begin with. And mental health is not as straightforward in many ways as physical health. Like you have diabetes, whereas mental health diagnoses are a little less black and white. So that's why, for me, just having some information, but letting the human use that information to inform their judgments, their clinical judgments, and all that type of stuff, just, means that we don't have to worry about the concerns of full automation, AI having based on models that aren't precise or to give false positives and false negatives. It's just trying to inform a manual human judgment in the end.
It's interesting.
Yeah.
Yeah, definitely.
And one final thing is, I think these systems, rather than trying to pinpoint an exact diagnosis or hone in on the one true thing or one true case, these technologies at the very least could just eliminate the implausible or impossible things, so that then the human condition can focus on the more probable or plausible scenarios and pick the one that they think is the correct one from that.
Makes sense. But from my reading in the literature of like transparency and assisted decision making, I think if you don't have a transparent system, though, people will tend to try to hand over the decision to the system because they just don't understand how it works, and they will think, oh, it must know, although
So for the dashboard, it's like, well, we've just got, say, some bar charts showing how many missed calls and taken calls a person has throughout the week, or a pie chart saying what app categories they've used the most.
Yeah,
that's to begin with. Yeah.
Any other questions? If you do try, you can also put things in the chat.
Or just email me if you have any, if you wake up in the middle of the night with a burgeoning question after having processed all this talking, then send me an email.
Cool.
All right. Thanks, everyone.
All right. Yes, thank
Thanks.
you, everyone.
See ya.